Yes, Dr. Helena, I can hear you.
Okay. Or if it's related to a metabolic regulation, since many of our hormones have a sleep-related cycle. The same thing goes for immune functions. None of those explanations would result in why do we need to be unconscious during that time of the day. And I think the couple of explanations that I have tried to get closer to that, the best is the evidence that there's some regulation of memory and synaptic plasticity in our brain during sleep, as well as a detoxification function. So there's some studies that have looked at the synaptic potentiation during the daytime, where our synapses, as we're learning and doing things during the day, reach a maximal or a high density during the night. And sleep allows these synapses to be regulated. And also with this regulation, there is some memory consolidation and circadian regulation. So it's part of our new, it's part of our ability to learn new things and also to modulate that memory in a way that is helpful for us. Most recently, there was a study that looked in mice at a circulation that was actually found in our brain only during times of sleep. And in this graph, in this cartoon, you can see they put a tracer that was only present at certain areas of the brain in orange when the mice was awake. And when the mice was asleep, this tracer diffused through the brain and allowed a sort of detoxification. And in this study, they looked at an ability to clear beta amyloid, which is what is found in people with Alzheimer's. So in a way, gives some light that sleep is important also to detoxify our brain. So having said that, when we think about how common are sleep disorders in children, they actually happen quite often. And they go from the most common things that we see in children that we call behavioral insomnia of childhood that can happen up to 30% of kids, or delayed sleep onset, or being a night owl, or prefer to be a late sleeper during teenage years, to also other disorders like obstructive sleep apnea that can happen up to 5%, rhythmic movement disorders, parasomnias like somnambulism, confusional arousals that can be sleep terrors, or nightmares in general. So they do happen quite often, and they can result in some health consequences. I'm going to start talking about insomnia, which is a common complaint in the pediatric clinic, and the most common one is the one we call behavioral insomnia. It's classified into two different types: the sleep onset association and the limit setting type. However, there's some other insomnias that are associated with comorbidities like ADHD, autism, or developmental disabilities that might be a little bit outside of the typical description of the sleep onset association and limit setting type. So the behavioral insomnia of the sleep onset association type is usually that a child gets used to fall asleep under certain conditions. And it's usually a parent that will soothe the child or rock them to sleep And then when normal awakenings happen in the middle of the night, the child is not able to fall asleep unless those situations that usually are present at the beginning of the night also happen at night. It is often known that babies in the first couple of months of age need to be rocked to sleep because they have a harder time soothing themselves to sleep. But after 2-3 months of age, they should be able to achieve this skill. And the most important recommendation that a pediatrician can give to a parent is to try to put the child drowsy but not asleep, so they learn to go into sleep without having the interaction with the parent every time that they wake up. When the kids become a little older, they might start requesting things like water, multiple trips to the bathroom, hugs, a story, or they might say they're afraid, and they do what we call curtain calls that may result in refusals to go to bed. And this is what we call limit setting type. Usually by setting good limits to the bedtime routine, these behaviors can improve. In the sleep literature, there is enough evidence-based techniques, behavioral techniques, to try to teach kids to resume sleep or initiate sleep on their own. And the most, I think, a known technique is the extinction or Farber, which is basically letting the child cry to sleep. And you ignore the behavior until the kid falls asleep without the parent's intervention. It requires a lot of consistency, and it could be difficult for many parents to listen to a child cry for a long time. So in the literature, there's now also a modified extinction technique in which you do a similar thing, but in a progressive manner, where you increase the time progressively that it takes for the parent to respond to the child, and also decrease the time total that it takes to soothe them to sleep. When there is quite a bit of a refusal and temper tantrums before bedtime, another technique that is pretty helpful is delaying the bedtime and then doing a positive bedtime routine, where the bedtime becomes a little bit more pleasurable until the child falls asleep. And as the child is able to fall asleep easier, then the parents can move the bedtime to an earlier time, night by night, in 15 minutes increment. And the last technique that I'm going to talk about is one that is used for kids that have a very consistent pattern of awakening at a certain time of the night, where the parents can wake them up a little bit earlier and try to then decrease the amount of awakenings overnight to try to get them to sleep through the night without 5 or 10 awakenings that may happen during the night. All these behavioral treatments have been validated by randomized controlled trials, and they do seem to improve the sleep onset latency, makes the kids fall asleep much quicker, as well as the frequency of night awakenings and the duration of the night awakenings. However, having said this, the evidence is basically found in kids that don't have any other comorbidities. So when you look at children, maybe adolescents, it's not that it's a comorbidity, but in another age group, adolescents or children with neurodevelopmental disorders, mood disorders, or chronic illnesses, these techniques may not be proven to be that helpful. In that situation, we can consider a sleep restriction, where we decrease the amount of time in bed by 15 minutes every 2 weeks, and then continue decreasing until the night awakenings go away. And if it's necessary, then the time can be given back to the child, also in 15-minute increments every 2 weeks. In some children, even though this is not, this is an off-label use, there's no FDA recommendation to use any sleep aid. In some children with other comorbidities, sometimes we consider using medications like melatonin, clonidine, clonazepam, trazodone, and in adolescents with insomnia, we can use cognitive behavioral therapy for insomnia. Another fairly common cause of difficulties initiating sleep or resuming sleep is what we call restless leg syndrome. And what it's basically describes a leg discomfort at bedtime, just when the child is at rest with an urge to move the legs. And it could result in difficulties initiating sleep at the beginning of the night, or if the child wakes up in the middle of the night. This could result in daytime irritability, sleepiness, and we often, even though we only have a clinical history to confirm this diagnosis, there's often a positive family history of restless leg syndrome. And in many cases, we can document an association with iron deficiency because iron plays a role in dopamine pathways that are thought to be related to restless leg syndrome. Restless leg syndrome is more known in the adult population. However, many adults with restless leg syndrome have reported that their symptoms started during childhood. And this kind of goes along with what we have seen in many childhood restless leg syndrome case reports. And basically what we're looking for is a child that complains of an urge to move their legs. They have some discomfort, and we want to have that description done by the child in their own words. And then kind of looking at whether this discomfort gets worse during periods of inactivity, and if it's relieved by movement or not. The restless legs tends to be worse at night. And on occasion, aside from the family history, we can also document periodically movements if the child was to have a sleep study. We don't necessarily use a sleep study to confirm restless leg syndrome, but there's an association between the two. The treatment for this is first trying to have sleep hygiene and avoid sleep deprivation with limit settings for bedtime and wake-up time, and also checking the iron levels. And if the ferritin is under 75, considering replacing iron. There are other medications that can be used if the iron treatment is not, it does not result in improvement, and that's with treatment with gabapentin and clonazepam. These are the most common medications used for children with restless leg syndrome. And lastly, I'm going to talk about another common cause of difficulties falling asleep, but in this case, it's mostly, I think, in teenagers. They are the population that are more prone to have this issue. Is a delayed in the sleep phase. And what we see is that teenagers normally tend to have a tendency to go to bed later and also wake up later. And during school days, when they have to wake up very early, this could result in chronic sleep deprivation Monday through Friday. This problem could present in children as insomnia because they have a hard time falling asleep, but also as a daytime sleepiness because they're chronically sleep deprived. In this curve, you can see what defines the sleep phase, which is the melatonin secretions. And in teenagers, it's a little bit delayed. It's normal, but it's delayed. And then they just have to wake up before they're done with their sleep. And this can result in different consequences, and one of them was documented in a school district in Virginia, two school districts. One of them changed the start time 85 minutes later, and they found that in the districts where the teenagers were able to start their school later, they had a decrease in the car accidents, and the decrease in the car accident was predominantly at the expense of teen drivers. Additionally, there is some evidence now that chronic sleep deprivation can result in obesity, and this could be because the sleep deprivation can change the appetite hormones and increase the hunger, but also that they may have more opportunities for eating and maybe less physical activity because they're fatigued. So they have an increased energy intake and decreased energy expenditure, resulting in obesity. So in summary about this issue in teenagers, especially in teenagers of delayed sleep phase, it's been documented that it can increase depression, it can increase suicidal ideation, drowsy driving, it can increase obesity, and it's associated also with poor school achievement. The CDC and the American Academy of Pediatrics have come up with recent recommendations to try to have a later start time for the high schoolers, as there's enough evidence that by doing this, we consistently allow them to have longer sleep, and if this longer sleep is not lost over time. It's not like they continue to go to bed later and later. It's maintained over time, and it allows them to rest much better. All right, so now switching gears to breathing disorders during sleep. And we talked about pediatric obstructive sleep apnea being a common disorder that can be present up to 5% of kids. The sleep disorder breathing, it's a continuum of different disorders where you can find just primary snoring, where there's noisy breathing, to upper airway resistance syndrome, where you might also find that the sleep architecture gets disrupted. Then you might start seeing obstructive hyperventilation with changes in the carbon dioxide or saturation of oxygen. And then finally, frank obstructive sleep apnea, when we also see an absence on the airflow along with disturbed sleep and changes in the ventilation. It can happen, the snoring can happen up to 10% of children, intermittent snoring up to 20% of children, and OSA can be seen in about 4% of preschool children. And it seems to peak between 2 and 5 years of age, kind of matching when the adenotonsillar growth peaks as well. Sleep apnea in children seems to have equal ratios between male and female, which is different in adults. And in terms of the distribution by race, we know here in the United States there's a higher prevalence in African American children. Different things can result in children having these problems. And we always think about structural abnormalities and whether a child has large tonsils, whether they have craniofacial anomalies or obesity. But there is also some evidence that changes in neuromuscular tone, as we see in cerebral palsy, neuromuscular weakness, or also what is proposed to be the reason why there's a familial predisposition with maybe changes in the neuromuscular tone of the airway. And there are other factors that can play a role too, that could be genetic and hormonal. So when you see all this and you find this group that is more susceptible to have a sleep apnea. And this is just a list of kind of the things that we've been talking about. If you see a child with adenotonsillar hypertrophy, they are at risk of obstructive sleep apnea, craniofacial anomalies, especially macrognathia or retrognathia. Kids with Down syndrome are at high risk of sleep apnea, as well as those with obesity and neurologic disorders that may result in low tone. If we were to try to diagnose sleep apnea just by the history, we actually can't get too far with that. There's only 3 things that have been proven to maybe be associated with a higher severity of sleep apnea, which is race, African American, physical findings like a high BMI, and questionnaire responses in the Pediatric Sleep Questionnaire and the Obstructive Sleep Apnea Questionnaire, 18 questionnaire. They have been associated with a higher severity, but they are poor predictors of whether the child has sleep apnea or not when you compare it to the sleep study. So we continue to look for a sleep study as a diagnostic test. Nonetheless, for screening, we ask the parents if the child has, during the night, snoring, if they have breathing pauses, if they have snorts, gasping, choking, if the sleep is restless, and if the parents find the kids being sweaty, or if they have increased work of breathing or an abnormal sleeping position, usually on a hyperextended neck position. And also if all of a sudden they start to have enuresis. During the daytime, kids are more sleepy, but also they may have behavioral problems. They may be more hyperactive. They may have a hard time paying attention in school. And those are things that we don't typically think in adults with sleep apnea, but in children that haven't had a good rest, usually hyperactive behavior with poor attention and kind of symptoms of ADHD are common side effects of the sleep disorder. We also should be asking for morning headaches as maybe a sign of accumulation of CO2 overnight, and nasal congestion and mouth breathing and adenotonsillar hypertrophy are such a common finding in sleep apnea. So as I mentioned before, the pediatric polysomnography, it's still important to diagnose sleep apnea in children. It's important to determine the need for treatment, and also to define the severity and the need for postoperative monitoring. Most children will be able to have a surgery like this and just go home the same day. But if they have a severe sleep apnea, further monitoring is warranted. Polysomnography or sleep studies are also helpful to when there's a differential, when narcolepsy is in the differential diagnosis for the child. And lastly, to evaluate the success of treatment, and this is mostly true in kids with severe sleep apnea. So the classification of sleep apnea in children is quite different than adults. And if you look at the adult literature, they use the apnea-hypopnea index, and the definition of sleep apnea is much higher than what is used for kids. So a normal apnea-hypopnea index in children is less than 1 event per hour. And mild obstructive sleep apnea is when the AHI is between 2 and 4. Moderate obstructive sleep apnea when it's 5 to 9, and severe obstructive sleep apnea when it's more than 10. And what is included in the sleep study: nasal and oral airflow, also an EEG, Untitled CO2, oximetry, EKG, impedance of the chest and abdomen for respiratory effort, and leg EMG, as well as EMG of the eyes to measure eye movement. And this is a graph of what we get to see in the sleep study. we see that there is an absence of airflow, as you can see in these flat areas these flat lines. However, the patient is making an effort to breathe, and you can see the thorax and the abdomen are moving, but there's an absence of airflow. And with this absence of the airflow, you can also see the saturation being intermittently decreased up and down along with the apneic events. In the EEG, you can also see events of arousals or sleep fragmentation that can result in tiredness or daytime sleepiness. So overall, when we try to compare what happens in obstructive sleep apnea in children compared to what we know in adults, they tend to have fewer obstructive events. They may have more hypoventilation due to their lower functional residual capacity and more desaturation with the events, oxygen desaturation. Kids, of course, tend to have a high respiratory rate and lower functional residual capacity. They tend to wake up less than adults, which results in preservation of the sleep architecture. And maybe it is the explanation for the different sleepiness that we see in children compared to adults. And overall, they tend to show more attentiveness and hyperactivity as part of their symptoms. Some of these also are related to the kids having smaller oxygen stores, and that's why their ventilation might be affected a little bit more. The only problem with polysomnography is that it's quite cumbersome. You need to go to a lab. It's expensive. It's difficult to get there, and there has been a suggestion. Is there anything under kind of a sleep study that could be helpful for diagnosis, like for example doing a NAP study? Unfortunately, the NAP study has found to underestimate the severity of obstructive sleep apnea. And the reason for that is because the NAP study may not include REM sleep. REM sleep doesn't happen until very late in the night. And if the child is going to a nap, they might not reach REM sleep. And as such, they might not get to the time of the night where they will have the most troubles. Home sleep studies have also been tried, and they are less expensive, but they may require more retesting as they are unattended, and they might result in the children pulling the monitors and removing the leads that could give false negative. Now, there was a study by Dr. Marcus done in 2014 doing a full PSG, including EEG leads at home. And they found that there was at least 75% of the recording was available in 92% of subjects. So it was feasible. However, it depends on the community where the sleep study is done and the resources that there is. And so far, the American Academy of Sleep Medicine does not recommend home tests for children. Now we're going to talk about what happens to kids with obstructive sleep apnea. They tend to actually have failure to thrive or difficulties gaining weight. In some of that consequence is thought to be related to maybe the child working really hard to breathe during the night, or the sleep disruptions resulting in disruptions in the insulin growth factor growth factor 1 pathway. And some studies have looked at what happens to the weight before and after surgery, and have found that actually weight tends to increase after the obstructive sleep apnea is treated. Additionally, there's enough evidence, very extensive evidence that there is a neurocognitive morbidity associated with pediatric sleep apnea. As I mentioned, most of the symptoms that we see are hyperactivity, inattention, aggression, maybe impaired school performance, daytime sleepiness, and also depression. So it's important that when we are considering behavioral problems in children or neurocognitive problems, we keep in mind whether it could be associated with sleep disorders because they are quite linked to each other. Lastly, I'm going to mention about the cardiovascular consequences of obstructive sleep apnea. We know that having low oxygen for long periods of the night can result in pulmonary hypertension. This is, however, quite rare and only associated with very severe cases of sleep apnea. But if it's happening for long enough, we can even find poor pulmonale in these children. Additionally, just systemic hypertension alone has been associated with obstructive sleep apnea. You can see in this cartoon how the higher the apnea-hypopnea index, the higher was the diastolic pressure. So it's something also to keep in mind. The treatment, the first line of treatment is usually in children surgical, and it goes to adenotonsillectomy that has a success rate of about 76%. And in some cases where children may have other sites of obstruction, like for example, kids with cerebral palsy, we can consider doing further surgery like uvulopalatopharyngoplasty or UP3. Craniofacial surgery in those who have retrognathia or micrognathia, and in those that have very severe sleep apnea, maybe considering tracheostomy as a surgical treatment. Some kids with very arched palate that may not have enough space for their tongue to stay, have a good position in the mouth, might respond to orthodontics rapid maxillary expansion. And aside from the surgical and orthodontic treatments, we have medical treatments that could include positive airway pressure, continuous or bi-level, weight loss if the child is obese, and intranasal steroids, which have a modest effect, and I mostly use it only in kids that may have mild obstructive sleep apnea. Adenotonsillectomy being the first line of treatment, you would think, well, if a child is obese or if a child has obstructive sleep apnea, is it still worth to do adenotonsillectomy? And it seems that there is, and the recommendation is to still go to adenotonsillectomy as the first line of therapy, but then reassess those groups that might be at higher risk of not having resolution because they have other risk factors like like Down syndrome or obesity. We mentioned earlier that doing a sleep study to determine the severity, it's important. And there has been a list of things that have been identified as risk factors for complications after a surgery that may require that the kid stays overnight, at least overnight, to make sure that there's no need for oxygen or any other kinds of support. So when the surgery is done in kids that are younger than 3 years of age, if the sleep apnea is severe by apnea-hypopnea index or by nadir of oxygen, if there's any associated medical condition like Down syndrome or neuromuscular disorders, craniofacial anomalies, neuromuscular disorders, I'm repeating that, if the child has had a recent respiratory infection, if the child has severe obesity or premature birth, and if there are already complications of obstructive sleep apnea, like failure to thrive or pulmonary hypertension or cor pulmonale. When surgery fails, though, we might go to positive airway pressure which might be very helpful in opening the airway by stenting the airway with the pressure through the mask. It could be challenging, however, to start CPAP in children, and you have to prepare yourself to try different mask sizes and style until you find the one that fits the child, and using behavioral techniques with the parents, trying to empower the children, doing positive reinforcement, desensitization, and if for some reason the parent is also on CPAP, doing even some role modeling. All of those things can help. For now, what kind of our practice for obstructive sleep apnea is that from the American Academy of Pediatrics is that all children get screened at the regular checkups for snoring. And then they are referred when they are high-risk patients like kids with Down syndrome. There's also a recommendation to do urgent evaluations if there's already concern of cardiorespiratory consequences from obstructive sleep apnea. And the recommendation is still that the diagnosis is done with a sleep study, with a tonsillectomy as a first-line therapy treatment, and inpatient monitoring in high-risk patients. And those who have severe sleep apnea may require postoperative reevaluation to decide if further treatment, like for example with CPAP, will be necessary. So I'm going to talk, this is the last part of the lecture, another piece of sleep issues that are quite common in children, which are parasomnias. Usually in kids we see parasomnias that are associated to non-REM sleep, or what we call disorders of arousal. However, there are other parasomnias related to REM sleep, like nightmares, and parasomnias related, other parasomnias are maybe, I guess you shouldn't call it parasomnias, but it may have the similar presentation and could be also seizures. The disorders of arousal tend to happen usually during non-REM sleep in the first half of the night. And what we see in younger kids is night terrors, and as the kids get older, then they have maybe more sleepwalking. These episodes may happen multiple times, and there's confusion, automatic behavior. Kids usually don't remember a bad dream, and they are usually able to return to sleep without any difficulty, and they actually don't remember the events most of the time. There's usually a family history of disorders of arousal, and if you have a relative that has had them, then you're tenfold increased risk for that. The night terrors are the disorders of arousal that we see early in life, that peak between 5 and 7 years of age, and they can be seen as often as 6.5% of children. Many kids that have night terrors will sleepwalk later in life, and about half of them will end by the age of 8. They tend to begin abruptly while the child is in non-REM sleep, and then they just have a very blood-curdling scream or cry. And what is interesting is that these kids are screaming and crying, and there's really no, the parents can't console them. They come and try to get kind of to hug them or to try to soothe them, and the child is really not being consolable or responding to them. There's usually an easy return to bed, and oftentimes the kids won't remember in the morning that has happened. And the somnambulism or sleepwalking is the other disorder of arousal that can maybe result in sometimes in injuries. And so it's important to know what is the complexity of the behaviors that they're doing, and whether there's any risk factors or any risk associated with this sleepwalking. Is a child trying to get out of the house or is trying to cook something or things in that matter. Usually, we don't need to do sleep studies to make this diagnosis of non-REM parasomnias unless there is a question that the events could be seizures, and this is usually when the spells are atypical, they have a stereotypical movements, and also if there's any question about the whether the behavior could be injurious or not. Sometimes when there's a concern that something could be waking up the child more than it should, like obstructive sleep apnea, there's a need to do a sleep study. The treatment is usually just letting the episode to run their course, bringing the child calmly back to bed, emphasize sleep hygiene because sleep deprivation can trigger any of these disorders of arousals, and try to do safety in the bedroom where if there's an option for the child to be in the first floor of the house, that would be better, and avoid bunk beds, and remove any sharp objects that could be injurious for the child. Sometimes there's motion alarms that can be put in their rooms where the parents can find the kids if they tend to try to wander or maybe try to get outside of the house. And the medications are usually necessary when the behaviors are may result in injuries and when they're happening more than 3 times a week. The most common treatment for disorders of arousal or sleepwalking is clonazepam. And once it's started, it's a good idea to reassess the symptoms every 6 months to see if the treatment is still needed. And this is kind of the end of the review. I'm happy to answer any questions that you may have.